Nursing Case Management for Congestive Heart Failure by Shauna Priest, Joy Martin Spriggs, and Kelly Murphy. California State University San Marcos School of Nursing, Nursing Case Management of Vulnerable Populations, Nursing 442, Professor Fidlow, October 16, 2016. Patient and chronic illness. DS is a 68-year-old Caucasian male hospitalized for a congestive heart failure exacerbation. DS presented to the emergency room with shortness of breath and complained of increased peripheral edema. He has been married to his wife, MS, for over 50 years and has 3 children who check up on the 2 of them periodically. DS is a retired auto mechanic and would be considered to be of middle socioeconomic status. He is also insured under Aetna insurance. DS was initially diagnosed with heart failure last year. In addition to this diagnosis, he has the following chronic conditions: hypertension, type 2 diabetes, arthritis, gout, morbid obesity, and high cholesterol. Medical treatments and nursing diagnoses. DS will be going home with the following medications: metformin, atenolol, hydrochlorothiazide, and simvastatin. He has also been instructed to continue checking his blood pressure daily, apply compression stockings to help with his edema, and will have supplemental oxygen as needed. He is to continue taking a daily weight and highly encouraged to adhere to a strict sodium restriction of less than 1.5 grams per day and a fluid restriction of less than 2 liters per day. In addition to the medical diagnoses, he has the following applicable nursing diagnoses: deficient knowledge, fluid volume overload, decreased cardiac output, impaired physical activity, self-care deficit, chronic pain, ineffective tissue perfusion, and activity intolerance. The nursing diagnosis most pertinent to his case management needs would be deficient knowledge, and his nursing case management strategy or intervention would be providing education relating to adherence to dietary restrictions of sodium and fluid. DS will receive telehealth monitoring and continued education services with a nurse educator bi-monthly upon discharge. According to Larson, telemedicine interventions for CHF clients has been shown to reduce number of nursing visits, improve patients' perceived quality of life, and decrease home health care costs. Excuse me. Self-capacity in comparison to chronic illness. According to Orum's theory of nursing as cited in Allspach, self-care can be described as, quote, comprising all of the voluntary activities that individuals undertake in order to maintain their health, life, and general well-being, unquote. The capacity at which is necessary to complete these tasks may range from simple and relatively easy to complex self-care activities requiring education and refined skills and training. DS has the capacity to complete certain aspects of his self-care, but also lacks the ability, education, and motivation to complete others. As mentioned in Larson, DS shows some of the factors that render his self-care insufficient, as evidenced by his, quote, misunderstandings, misconceptions, and lack of knowledge, end quote. Self-care behaviors focused on his CHF exacerbation and chronic disease conditions include medication administration, blood pressure monitoring, compression stocking application, elevation of his lower extremities, weight monitoring, sodium and fluid restrictions, dietary compliance, appointment management, and oxygen monitoring. DS has been successful with most of his chronic disease management, but has been non-compliant with dietary aspects of his self-care and has not been monitoring his weight or adhering to fluid and sodium restrictions. Measuring the capabilities of an individual's ability to perform his or her activities of daily living, or ADLs, can be an indication of the degree of disability with his or her disease. According to Larson, basic ADLs include personal care and basic survival tasks such as eating, bathing, dressing, going to the bathroom, maintaining personal hygiene, and mobility. Whereas instrumental activities of daily living, or IADLs, can include functions such as, quote, cooking, cleaning, buying groceries, doing yard work, and paying bills, unquote. According to Dunley et al., predicting factors of difficulty at performing ADLs include older age, male sex, diabetes, cerebral vascular disease, dementia, anemia, morbid obesity, and unmarried status. DS exhibits 4 of these predicting factors, including older age, male sex, diabetes, and obesity. He currently has a high functionality with the majority of his basic ADLs, yet is having increased difficulty performing IADL, such as grocery shopping, cleaning, and performing yard work. DS receives functional assistance from his wife and children in those specific aspects of his care. Some of the barriers identified to DS's self-capacity are behavioral, while others have been the potential to improve with increased resources and education. Ideal discharge planning. According to the Agency of Healthcare Research and Quality, quote, discharge from hospital to home requires the successful transfer of information from clinicians to the patient and family to reduce adverse events and prevent readmission, unquote. The ideal discharge planning model is endorsed by the AHRQ and used to help engage patients with their care. We can implement this system to identify priority areas for discharge planning with DS. Under I, we are going to include DS and his family in the discharge planning process. We will ask some questions and identify their needs and concerns about transferring to the home setting. Under D, we will discuss key areas that put patients at risk for readmission. These include asking DS and MS what their daily routines include. We will also review his medications and make sure he understands what each medication is for, when to take them, how to take them, and when to report side effects to the nurse or doctor. We will go through key warning signs and symptoms of CHF that warrant immediate physician notification. We will go over pertinent test results and schedule follow-up appointments with his cardiologist and primary care physician. We will also make sure DS knows when his telehealth appointments are and how to get in touch with his case management, nurse educator, and any additional needed resources. We know that DS has an issue with dietary compliance, so ensuring that he remains on target with the goals that we set upon discharge will be our priority issues. Under E, we will continue to take any opportunity during his hospital stay and encourage encounters to educate DS and the family in their preferred language about his prognosis, discharge process, and what the next steps in his care are. Under A, we are going to utilize the teach-back method to assess how well the nurses and doctors have explained DS's conditions, prognosis, and discharge instructions. If needed, we can provide additional teaching and resources. And lastly, under L, we will listen and honor DS's goal for care, his preferences, and his concerns.